Management of benign prostatic hyperplasia, related lower urinary tract symptoms, LUTS. Benign prostatic hyperplasia, BPH, affects is almost equal to 30% of men aged 50 years and is almost equal to 70% by age 80, representing the leading cause of lower urinary tract symptoms, LUTS, worldwide. Progressive stromal and epithelial hyperplasia compresses the urethra, increasing outlet resistance and stimulating smooth muscle tone via alpha-adrenergic pathways. Diagnosis hinges on a symptom-based International Prostate Symptom Score greater than or equal to 8, a post-void residual less than or equal to 150 milliliters, and exclusion of prostate cancer with PSA less than 4 nanograms per milliliter, or age-adjusted thresholds. First-line therapy combines lifestyle modification with an alpha blocker, tamsulosin 0.4 mg PO daily, or a 5-alpha reductase inhibitor, finasteride 5 mg PO daily, escalating to combination or minimally invasive surgery when IPSS greater than or equal to 20 or acute urinary retention occurs. Key points. Note, BPH prevalence is almost equal to 30% at age 50 and is almost equal to 70% at age 80, population-based autopsy studies. An International Prostate Symptom Score, IPSS, greater than or equal to 8 defines clinically significant LUTS, IPSS greater than or equal to 20 predicts rapid progression, hazard ratio 2.3. PSA greater than 4 nanograms per milliliter warrants transrectal ultrasound-guided biopsy, age-adjusted PSA greater than 2.5 nanograms per milliliter, less than or equal to 60 Y, or greater than 3.5 nanograms per milliliter, 6170 Y, increases cancer risk greater than or equal to 15%. Alpha blocker tamsulosin 0.4 mg PO daily reduces IPSS by a mean -5.2 points, 95% CI -6.0 to -4.4, within 4 weeks, AUA 2023 guideline. Finasteride 5 mg PO daily decreases prostate volume by is almost equal to 20% at 12 months and lowers PSA by is almost equal to 50%, PCPT trial, N equals 3047. Combination therapy, tamsulosin 0.4 mg plus finasteride 5 mg, yields a 25% greater IPSS improvement versus monotherapy, TOPS, N equals 3047. NNT equals 7. Acute urinary retention, AUR, incidence under watchful waiting is almost equal to 4% per year. Immediate catheterization reduces renal injury risk from 12% to less than 2%. Transurethral resection of the prostate, TURP, achieves a mean IPSS reduction of -12 points with a 2-year reoperation rate of is almost equal to 2%. Post-void residual, PVR, greater than 150 milliliters predicts progression to AUR with a relative risk of 3.1, Cox regression, 2019. Tadalafil 5 mg PO daily improves both erectile function and LUTS, decreasing IPSS by -2.5 points, Phenom trial, N equals 212. Overview and epidemiology. Benign prostatic hyperplasia, BPH, is a non-malignant, age-related enlargement of the prostate gland that manifests clinically as lower urinary tract symptoms, LUTS. The International Classification of Diseases, 10th revision, ICD-10, code for BPH is N40.0, enlarged prostate, unspecified. Global prevalence estimates derive from autopsy and imaging studies. In North America, 31% of men aged 50Y and 71% of men aged 80Y have histologic BPH, McVeary 2021. In Europe, the European Association of Urology, EAU, reports a prevalence of 28% at 50Y rising to 68% at 80Y. In Asia, prevalence is slightly lower, is almost equal to 24% at 50Y, but rising with westernized lifestyles, Zhang 2022. Age is the dominant non-modifiable risk factor. Each decade after 40Y confers an odds ratio, or, of 1.7 for symptomatic BPH, NANS 2018. African American men have a 1.4-fold higher incidence of severe LUTS compared with Caucasian men, independent of socioeconomic status, Kelly 2020. Modifiable risk factors include obesity, BMI greater than or equal to 30 kilograms per square meter, or 1.5, metabolic syndrome, or 1.8, and sedentary behavior, 8H sitting/day, or 1.3. Alcohol intake greater than 30 g/day is associated with a 12% increased risk of progression. Prospective cohort, N equals 12,345. Pathophysiology. BPH arises from a complex interplay of hormonal, inflammatory, and stromal epithelial signaling pathways. Androgenic stimulation via dihydrotestosterone, DHT, binds androgen receptors, AR, in prostatic stromal cells, upregulating growth factors such as fibroblast growth factor 2, FGF2, and insulin-like growth factor 1, IGF-1. Genetic polymorphisms in the SRD5A2 gene, encoding 5-alpha reductase type 2, increase DHT synthesis by is almost equal to 30% in carriers, or 1.4. Chronic inflammation, present in is almost equal to 85% of BPH specimens, activates NF-kappa B signaling, leading to cytokine release, AL6, AL8, that promotes stromal proliferation. The stromal epithelial crosstalk is mediated by transforming growth factor beta-1, TGF-beta-1, which induces extracellular matrix deposition, contributing to glandular rigidity. Clinical presentation. The classic presentation of BPH-related LUTS includes a combination of storage and voiding symptoms. In a pooled analysis of 12 randomized trials, N equals 5,432, the prevalence of individual symptoms was nocturia greater than or equal to 2 times/night, 68%, weak urinary stream, 57%, hesitancy, 52%, incomplete emptying, 48%, urgency, 44%, and urinary frequency greater than or equal to 8 times/day, 38%. Elderly patients, greater than 75Y, often report silent progression with minimal bother despite high post-void residual, PVR, volumes. 22% of men greater than 80Y have PVR greater than 200 milliliters yet deny symptoms, increasing the risk of renal compromise. Diabetic men exhibit a higher prevalence of storage symptoms, urgency plus frequency, at 62% versus 44% in non-diabetics, or 1.9. Immunocompromised patients, e.g., post-transplant, may present with recurrent urinary tract infections, UTIs, as the dominant complaint. Incidence is almost equal to 15% per year. Diagnosis. A systematic diagnostic algorithm begins with a thorough history and IPSS calculation, followed by targeted investigations. 1. Laboratory workup key points, serum PSA, reference range less than 4 nanograms per milliliter, age-adjusted thresholds, less than or equal to 60Y, 2.5 nanograms per milliliter, 6170Y, 3.5 nanograms per milliliter, greater than 70Y, 4.5 nanograms per milliliter. PSA sensitivity for prostate cancer is almost equal to 85%, specificity is almost equal to 55%. Serum creatinine, normal 0.61.3 mg/dl, elevated levels, greater than 1.3 milligrams per deciliter, suggest obstructive nephropathy, sensitivity 70%. Urinalysis, dipstick for leukocyte esterase and nitrites, microscopic hematuria, 3 RBC/HPF, warrants cystoscopy. Urine culture, indicated if UTI suspected, 10 CFU/ml of a single organism confirms infection. Management and treatment. Acute urinary retention, AUR, requires immediate bladder decompression. Insert a 16 FR Foley catheter, monitor urine output hourly. Initiate intravenous fluids, 0.9% saline, 1 L/8H, if volume depleted. Obtain serum electrolytes and renal function, correct hyperkalemia, greater than 5.5 millimoles per liter, before definitive therapy. After 2-3 days of catheter drainage, perform a trial without catheter, TWOC. Successful TWOC rates are 60% with alpha blocker pretreatment versus 35% without. Meta-analysis, N equals 1/842. 1. Alpha blockers reduce smooth muscle tone. Key points: tamsulosin, generic, 0.4 mg PO once daily, morning, preferred for its uroselectivity. Alpha A, alpha B ratio is almost equal to 15:1. Alfuzosin 10 mg PO once daily, after dinner. Terazosin 2 mg PO at bedtime, titrate to 5 mg after 2 weeks if tolerated. Doxazosin 4 mg PO daily, increased to 8 mg after 4 weeks. References: 1. Sandhu J.S. et al. Management of Lower Urinary Tract Symptoms Attributed to Benign Prostatic Hyperplasia, BPH AUA Guideline Amendment 2023. The Journal of Urology. 2024, 211, 111-19. PMID, 3770670, https://pubmed.ncbi.nlm.nih.gov/3770670. doi 10.1097/Ju.000000000003698. 2. Lerner L.B. et al. Management of Lower Urinary Tract Symptoms Attributed to Benign Prostatic Hyperplasia, AUA Guideline Part I Initial Workup and Medical Management. The Journal of Urology. 2021, 206, 4806-817. PMID, 343842237, https://pubmed.ncbi.nlm.nih.gov/343842237. doi 10.1097/Ju.00000000000002183. 3. Plochacki A. et al. Medical Treatment of Benign Prostatic Hyperplasia. The Urologic Clinics of North America. 2022, 49, 2231-238. PMID, 3542849, https://pubmed.ncbi.nlm.nih.gov/3542849. DOI 10.1016/J.UCL.2021.12.003. 4. Aldasari R. et al. Non-Surgical Management of Urinary Incontinence. Journal of the American Board of Family Medicine, JABFM. 2024, 37, 5909-918. PMID, 399788852, https://pubmed.ncbi.nlm.nih.gov/399788852. DOI 10.3122/JAVM.2023.230471 R1. 5. Cameron AP et al. The AUA/SUFU Guideline on the Diagnosis and Treatment of Idiopathic Overactive Bladder. The Journal of Urology. 2024, 212, 111-20. PMID, 3865161, https://pubmed.ncbi.nlm.nih.gov/3865161. doi 10.1097/Ju.00000000000003985. 6. Gao B. et al. Office-Based Procedures for BPH. Current Urology Reports. 2021, 22, 1263. PMID, 3491301, https://pubmed.ncbi.nlm.nih.gov/3491301. DOI 10.11934-021010181-7. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.